So, hello, I'm Brian Darlow, a neonatologist from Christchurch in New Zealand, and I've had a long interest in retinopathy of prematurity. So this talk, which follows on from the talk that Professor Claire Gilbert has given, is about primary prevention of retinopathy of prematurity. And I'm going to emphasise that primary prevention is the key and that a lot more can be done in all settings. The variation that we see in incidence between centres is a big clue to what is possible. I'll talk mostly about proven and just a little bit about investigational therapies that have a role in prevention. I'll talk about oxygen saturation targeting and go over the recent trials and meta-analysis of oxygen saturation targeting and the implications of those. And I'll touch on the role of nurses and the team approach. So Professor Gilbert showed you this important research, which on the top graph shows the incidence of severe retinopathy of prematurity in a number of high-income countries. And it's confined to babies less than 32 weeks and less than 1,500 grams. And in fact, mostly less than 30 weeks and less than 1,250 grams. On the bottom is the incidence of severe ROP in a range of middle-income and developing countries. And you'll see that there are many larger and more mature babies who get severe ROP. And the important point is that with current knowledge, we already know how to prevent most of these babies getting ROP. The improvement that we see in high-income countries compared with middle-income countries to some extent comes from what I call big-ticket items, so requiring quite a lot of financial investment, changes in organisation and the delivery of care, organising obstetric units into high-risk units that receive antenatal transfers of mothers at risk of preterm delivery, and regionalisation of neonatal care and good neonatal transport for the few occasions when babies are not born where the neonatal unit is. Alongside that has been the rise of neonatal networks. So this is like-minded units getting together to collect a common data set on high-risk infants, and this allows ongoing audit and quality improvement programs. But at the same time, there are much cheaper changes that have led to improved care. One is having interdisciplinary collaboration between doctors, nurses, allied health workers, and involving parents and administrators. And then the use of evidence-based medicine and having agreed evidence-based medicine protocols. And many of these interventions are actually low-tech and inexpensive. So this is showing mortality for the Vermont-Oxford network, 350 centres shown in this particular slide. And the units on the right-hand side have twice the mortality of units on the left-hand side. The vertical bars indicate the size of the unit, so if it's a wide bar, it's a small unit. If it's a narrow bar, it's a large unit, and you can see these are spread throughout. So there's huge variation in mortality for high-risk infants across the centres. And the similar data for severe retinopathy of prematurity, this comes from the Canadian Neonatal Network. It does look as though the better units on the left-hand side are generally larger units with small confidence intervals, but not exclusively so. There are some small units that get good outcomes as well. So what are the reasons for this variation between units? Well, it could be differences in case mix. They could be looking after different sorts of babies. Some are sicker than others. Certainly differences in size of neonatal units will have an effect, with smaller units having bigger variation year to year. There could be differences in case ascertainment. So in the case of retinopathy of prematurity, despite the international classification you've heard from Professor Gilbert, two ophthalmologists looking at the same eye may come up with a slightly different assessment. But most importantly, there will be differences in care practices. Now, we need to be aware that retinopathy of prematurity is certainly multifactorial. Different things affect it. It's more frequent in sicker babies. And also that interventions which are aimed at decreasing other comorbidities frequently also decrease the incidence of retinopathy of prematurity. So bronchopulmonary dysplasia, retinopathy of prematurity, necrotizing enterocolitis, intraventricular hemorrhage are often dubbed the free radical diseases of prematurity, meaning that they have a very related pathogenesis. Interventions aimed at keeping very preterm babies more stable also decrease the incidence of retinopathy. So it's the summation of care which counts. Retinopathy is actually a very good index of the overall quality of care. I'm just going to take a couple of slides to extend the talk that Professor Gilbert has given you about how ROP arises and talk about what we know about the pathogenesis of ROP. And this has really been established from rodent models of oxygen-induced retinopathy. So in utero, the retinal growth is under the control of several factors, and these include oxygen-regulated hypoxia-inducible factor and vascular endothelial growth factor, and the non-oxygen-regulated insulin-like growth factor 1, IGF-1. VEGF is induced by hypoxia, low oxygen, and inhibited by hyperoxia. And IGF has a permissive action, meaning it is required for VEGF to be able to work. In utero, normal vessel growth takes place from the optic disc under the control of IGF-1, which is produced from the placenta, and VEGF. So if a baby is born prematurely, it's immediately cut off from the placenta and that source of IGF-1, and that, together with the change from a low oxygen environment to out in air, the relative hyperoxia further suppresses VEGF, and that means that the vessels stop growing. And then as the neural retina develops, there's increasing oxygen demand and relative hypoxia, and that results in higher levels of VEGF. Now, if there's sufficient IGF-1, there can be normal vessel growth, but if there's excess VEGF, proliferative ROP may occur. So what are these different care practices? One of the most important ones, antenatal, is the use of antenatal steroids. This has been shown over many years to have a significant impact on improving survival by about 40%, reducing the incidence of hyaline membrane disease, and they've also been shown to have benefit in terms of reducing intraventricular hemorrhage, white matter injury, and severe ROP. The WHO have a strong recommendation that antenatal steroids should be used less than 35 weeks gestation, provided the gestation is known pretty accurately, that preterm birth is imminent, meaning within the next 7 days, and obstetric care is available. And then in labour ward, we talk about the golden hour, in fact also the golden minute, because the first minute and the first hour are so crucial for these babies, and practices in labour ward over this time have changed quite radically in recent years. One of these changes is delaying cord clamping by 30 to 60 seconds. So a meta-analysis of 15 trials showed that this decreases intraventricular hemorrhage, necrotizing enterocolitis, and sepsis. And last year there was a very large trial involving 1,500 infants, and this has been added into a more recent meta-analysis which shows that delaying cord clamping for 30 seconds or more reduces hospital mortality very significantly. It also leads to a raised hematocrit, PCV, and a decreased need for red blood cell transfusions, and both those latter things are related to ROP. So the American Academy of Pediatrics has endorsed the American College of Obstetrics and Gynecology recommendation that delayed cord clamping for 30 seconds should be used for all vigorous preterm infants. If the baby is very flat, of course, that would not be done. The second thing is preventing hypothermia. This is very easy and very cheap again. Babies can be covered with a plastic occlusive wrap or put into a plastic bag, and this is very effective at preventing hypothermia. The number needed to treat is 4, which is one of the lowest in any randomized controlled trials of anything. It's been shown that this does work in middle income situation, and having a baby arrive in the neonatal unit with an optimal temperature around 37 degrees has also been shown to lead to a lower rate of severe ROP. The last thing is avoiding 100% oxygen. So the recommendation is now that babies are started in either air to 30% oxygen. If a blend of oxygen and air is not available, then you should start with air. If you need to move to 100% oxygen, then it's absolutely imperative that you return to a lower inspired oxygen as soon as possible. And we have overall a gentler approach to respiratory management, avoiding intubation as far as possible and commencing with nasal CPAP. Once the baby gets to the neonatal unit, there are many factors in care that are important, and we've characterised some of these as the points of care. So P stands for pain control, oxygen for oxygen monitoring, and I will talk about that. And then infection control and nutrition, and these are the two areas that I think most units in all settings are likely to be able to make the greatest improvement in. Temperature control I've talked about, and supportive developmental care, positioning the baby in a good way, involving the parents using kangaroo care. Caffeine is used almost universally in very preterm babies to prevent apnea, and it's been shown in a very large, well-designed randomized controlled trial to have significant benefit for that. But in that trial it was also shown that it reduced death and disability in the long term, and also that severe ROP was significantly reduced. In fact, caffeine is probably the only treatment being shown to reduce ROP in that way. Interestingly, 11-year follow-up of babies treated with caffeine, they were shown to have better visual motor integration, visual perception, visuospatial organisation than babies not treated with caffeine. Quite why caffeine has a benefit in this way is a little bit unclear, but caffeine-treated babies did have lower rates of severe lung disease and were possibly more stable, but caffeine also has anti-inflammatory actions. So breast milk, there are many reasons that you'll all be very familiar with to support early and continued feeding with mother's own breast milk, but it has been shown in case control or cohort studies of babies who had at least some breast milk compared with babies who had none at all, that any amount of human milk reduces the rate of any ROP and also of severe retinopathy prematurity. Now, breast milk does have higher levels of IGF-1 compared with formula, but aside from breast milk, optimal nutrition, calories and growth is really important in these babies, and breast milk may often need to be supplemented to achieve this. Good nutrition is absolutely crucial at the time of brain development and is the key to better long-term outcomes. And there are now numerous studies linking poor postnatal growth with increased risk of ROP. In fact, poor postnatal weight gain has been used to improve predictions of which babies should be examined and perhaps treated for ROP. And Professor COINN in the next talk, I'm sure, will come back to this topic. This poor growth may be linked to poor production of IGF-1. In the baby, IGF-1 is made in many organs and tissues, including the liver, and both poor nutrition and infection will lead to lower levels of IGF-1. So IGF-1 replacement therapy is being considered, but it's difficult to do, and at the moment the trials are somewhat inconclusive. But there is a big research effort to be able to improve nutrition in our babies in the first few weeks of life. Prevention of sepsis, again, is desperately important in these babies, both to reduce death and serious morbidity. And sepsis, both early onset sepsis and later sepsis, and particularly candida sepsis, have all been linked with increased rates of retinopathy of prematurity. We used to think that sepsis was an inevitable consequence of being born very preterm and being in neonatal intensive care. We now know that's not the case, and we can reduce and even eliminate postnatal sepsis in these babies, and usually a bundle of measures is required to do this. So this is just a diagram of a long line, a spaghetti line, some people call it, and you can see there are many opportunities for the baby with this line to become septic. Where it enters the skin, organisms can end. Where you draw back blood from the line, that can lead to contamination. There can be contamination in what you infuse into the line, And if you have bugs floating around in the bloodstream and you have a piece of plastic in the bloodstream, then you're much more likely to get a nidus of infection. So there's been a big emphasis in preventing central line-associated bloodstream infections. Partly this is a culture change in the unit, viewing this as preventable and not inevitable. In our unit and many other units now, you have to be certified in line placement before you're allowed to put in a line like this, or indeed to maintain it or use the line. But other things lead to increased rates of sepsis in the units. If the unit is overcrowded, if the layout isn't optimal. Hand hygiene is probably still the most important intervention. No one should be too posh to wash. That's from cleaners to paediatric surgeons, who are particularly notorious for thinking they don't have to wash their hands. And I think you'll all be familiar with the WHO's 5 moments approach to preventing sepsis through hand washing. Using breast milk and perhaps probiotics and thinking about gut care may also reduce sepsis rates. We need to be very careful about antibiotic usage, using just narrow spectrum antibiotics when possible and stopping early when the blood cultures are negative. We need to involve parents in this whole prevention effort as well, so they're aware of what's going on. And clearly we need to monitor sepsis rates and produce regular feedback reports. And when you do all this is just an example from 13 units in North Carolina, showing their sepsis rates before the intervention was introduced, and you can see the dramatic decline in sepsis rates with this bundle of interventions they introduced. Nurses, of course, and you'll be well aware of this, have a key role in looking after these babies. And there are quite good data relating outcomes to nursing workloads. A UK study some years ago now looked at risk-adjusted mortality, and this was inversely related to the provision of nurses with specialist qualifications. And risk-adjusted mortality was also reduced with higher nurse-to-infant ratios. More recently, there have been decreases in one-to-one nursing in the UK, and that's been associated with increases in hospital mortality for these very preterm babies. And again, as I'm sure you're aware, better nurse-infant ratios improves the ability to achieve oxygen saturation targeting, which leads nicely on to the topic of oxygen, which is in fact the commonest drug we give to these preterm babies. And we absolutely need to be as careful with the amount of oxygen we give as with any other drug. Both too much and too little may cause harm. So there are 2 main factors regarding oxygen in the unit. One is avoiding too little and too much, hypoxemia and hyperoxemia. But the other factor is avoiding wide and frequent fluctuations in oxygenation. And both of these require oxygen saturation monitoring. This is an absolutely essential item of equipment in all settings, and it really is very difficult to look after these babies adequately without oxygen saturation monitoring. There need to be agreed oxygen saturation targets and alarm limits and protocols for what to do when the alarms go off. So this figure just shows the oxygen dissociation curve. On the bottom is arterial PaO2, or oxygen tension, and this is the value which determines how much oxygen gets to the tissues. On the y-axis is oxygen saturation, and when the oxygen saturation gets to about 95, the oxygen dissociation curve is a straight line, meaning it's almost impossible to know what the oxygen tension will be. It could be 80 or it could be 150. In the past, we've measured oxygen tension by, we've measured oxygenation by taking a blood gas and measuring oxygen tension, but from about the year 2000, oxygen saturation monitoring has been used almost universally because it's non-invasive and continuous. The other thing I just want to point out in this figure is that in utero, the fetus is in a low oxygen environment with a low PO2 and a low saturation. But as soon as it's born, the saturation comes up into the 90s over about 10 minutes. So from the 1990s onwards, as I've said, oxygen saturation monitoring was adopted. 2007, the American Academy of Pediatrics endorsed an oxygen saturation target of 85 to 95% as being pragmatic, but they noted that the optimal range was unknown. So this was expert opinion. And actually from the 2000 onwards, there was a trend to use lower and lower oxygen saturation targets. This was supported by various observational studies, and this was mainly to avoid the problems of bronchopulmonary dysplasia and retinopathy of prematurity. But it really was unclear where the balance should lie to minimize the harm from too much or too little oxygen and the competing adverse outcomes of death or neurodevelopmental impairment, bronchopulmonary dysplasia, and retinopathy of prematurity. So in 2003, a group, international group of neonatologists got together to try and design randomized controlled trials to address this problem. And there was an agreement that the study would involve infants less than 28 weeks gestation. We would look at a lower oxygen saturation target, that's 85 to 89%, and compare this to a higher target, that's 91 to 95%, within that range that the AAP recommended. And the primary outcome would be death or major disability at 2 years of age. So this was comparative effectiveness research, in other words, comparing two protocols which were in common usage around the world. At the outset, there was an agreement that when all the trials had finished and been published, they would be reanalyzed by an individual patient data meta-analysis, that is, treating all the data as if it was one trial. And that would be 5,000 babies, and that would have adequate power to answer the question we were interested in. So 5 trials have been published. This is the standard Cochrane meta-analysis of these trials, which was published last year. And just this month, the individual patient meta-analysis has been published. Again, this is looking at all the data as if it's one trial. This allows both the individual trial investigator and common definitions to be used for things like growth retardation and neurodevelopmental disability, and it gives the ability to particularly explore subgroups. Actually, the answers from both the Cochrane collaboration and the NeoProm IPD are the same, and shown in this slide, that in extremely preterm infants targeting a saturation 85 to 89% compared with 91 to 95% had no significant effect on death or major disability alone, including blindness, but was associated with an increased risk of death by 28 per thousand treated babies, or if you like, 2.8%, of severe necrotizing enterocolitis by 23 per thousand treated babies, and decreased the risk of ROP by 40 per thousand treated babies. So the rate of mortality in the low target was 19.9%, compared with 17.1% in the high target. There's a big caveat with this. This was carried out in babies less than 28 weeks gestation in a high resource setting where there was timely retinal examination and treatment available. And in that setting, severe visual impairment and blindness was very low in both target groups in all the studies at around about 1%. So how do we interpret this evidence? Well, all analyses and commentaries now recommend using a saturation target above 85 to 89% to decrease deaths and necrotizing enterocolitis. It's important to emphasize that the trials were about oxygen saturation targets and did not address alarm limits. So the alarm limits are still based on expert opinion, but most expert opinion suggests putting the upper alarm at 95% to avoid hyperoxemia, and the lower alarm should always be set higher than 85%. So my recommendation is the saturation target should be 90 to 94%, not 91 to 95, 90 to 94, so that you can set the alarms at 95% and 89%. This is higher than we've used before, and this comes back again to emphasising the importance of other aspects of primary prevention, that points of care protocol I've talked about. Before these studies were carried out, it was shown there was better compliance with saturation targets when the higher line was just 1% above the target and the lower line was 1 to 2% below the target. More mature infants and other settings, well, it may depend a little bit upon resources. WHO, before all these studies were published, had recommended a range of 88 to 94 with the alarm set at 95 and 86%. And I think that still seems reasonable. The other aspect of looking after these babies is keeping them as stable as possible that I've mentioned. And certainly animal studies indicate that fluctuations in oxygenation may be a more important trigger of ROP than hyperoxia alone. And there's some human observational data that suggests the same things. And certainly longer, more variable hypoxemic events have been associated with increased risks of severe ROP. So how do we keep the babies stable? Well, we need agreed protocols on saturation targets and agreed alarm settings and what to do when the alarms sound. We need good nurse training and adequate nurse-infant ratios, as I'm sure you will appreciate. And we can avoid wide fluctuations through better temperature control by avoiding inappropriate handling and having appropriate handling, such as kangaroo care, avoiding painful episodes, preventing sepsis. Again, these are all the interventions we talked about in the points of care idea that I introduced earlier. So how often are the evidence-based protocols that we know about introduced? Well, this is interesting work from Europe involving over 7,000 babies, and they looked at evidence-based practices in the labour ward. They looked at 4 practices particularly, and only 58% of babies who were eligible for these practices received all 4 of them. And after adjustment, evidence-based practices were shown, when they were used, were shown to reduce hospital mortality and severe morbidity. So we can all do more. This is data from a very large neonatal care network in the United States. They care for 30,000 very low birth weight babies a year. 2004 and 5, they had a big quality improvement focus on retinopathy prematurity. I have an educational program on ROP. Doctors and nurses, and in fact parents, were involved in this. There were stickers on the isolette about what the oxygen saturation target should be. They were able to reduce the rate of severe ROP from 11% to 5.8%. And more recently, they've extended this to what they call the 100,000 Babies campaign. They're looking at many key drivers to morbidity in the unit: nutrition, medication, central line care, respiratory care, delivery room care, and having quality improvement programs involving all of these aspects of care. And they further reduced the rate of severe ROP from 5.9% to 4.1%, as well as reducing mortality and other morbidity. So it is possible. This is data from the Vermont-Oxford network again. The y-axis on the left, you can see an orange line, and that indicates where the best 10% of units in terms of rates of severe ROP are concerned. The blue line is the best 25% of units where as far as severe ROP is concerned. If you go along to the right-hand side of the graph, in 2014, the blue line, 80% of units are now achieving the same rate that the best 25% of units were achieving back in 2004, and 45% of units are achieving the same rate as the best 10% of units were using in 2004. So improvement is possible. And it's not confined to high income settings. This is nice work in India, again showing that quality improvement programs, particularly focusing on antenatal steroids, oxygen, nutrition, sepsis and supportive care, were associated with a significant reduction in any stage of ROP, severe ROP as well. So in summary, retinopathy prematurity has multiple factors in its causation. It's a good index of the overall quality of care. Neonatal units should fully implement agreed evidence-based protocols. Saturation targets have changed to higher than they were formerly, and we should now avoid 85 to 89%. My recommendation is to set the upper alarm at 95% to avoid hyperoxemia. And we also need to avoid fluctuations in oxygenation. Nurses, as you know, have a key role in delivering evidence-based care, and poor staffing threatens the quality of care. Further prevention of ROP is possible in all settings, but may require a culture change. And you can read about some of these things in this journal, which is in fact freely available online. So thank you very much. In the next talk, Professor Graham Quinn will talk about screening and treatment of ROP.